Today, we're going to be talking with Dr. Jason Sager, founder of Sagely Health, about a story that came out in the New York Times over the summer. In June, the New York Times did a report on a cancer study in which 18 out of 18 of the patients responded and kind of had their tumors melt away. Let's just start with, why did they do this study? What were they thinking they might be able to achieve by doing this study?
Yeah, it's a great question to begin with. And for me, this is science that represents a real a history over the last 5 years as we started to look at immunotherapy and who immunotherapy can really work well in. Their immunotherapy is when the body is basically taught by the use of these medicines and instructed to attack the tumor and get rid of the cancer itself. And that's a very exciting thing. Before immunotherapy, diseases like melanoma were death sentences, largely if it was metastatic. And now with immunotherapy, specifically drugs called checkpoint inhibitors, there's a few leading ones. There's actually quite a number of these now. We are producing up to 50% cures in melanoma. Scientists started to say, well, how do we go outside of melanoma and expand that to other groups, other patients? And what they realized is that tumors that have a lot of genetic instability, it's called, where there's a lot of mutations happening sort of all the time and other changes in the tumor, that those patients, it's a small subset of patients, about anywhere from 3 to 10%, depending upon the cancer type. But that subset of patients seems to be really well set up to respond to immunotherapy. At first, they looked at a group of patients called colorectal cancer. Colorectal cancer is a combination of 2 types of cancers, colon cancer and rectal cancer. Oftentimes, though, colon cancer is more common, and so those studies were full of colon cancer patients, not so many with rectal cancer. And so, but they were looking for this signature called microsatellite instability, abbreviated MSI. And again, that's just a way of basically saying that this tumor has more mutations and generates more mutations than sort of other cancers. And there's a mechanism for that, and that's called MSI-High. And so they selected patients for this study, looking specifically now at rectal cancer, because they had already shown that in colorectal cancer, it works pretty well, and it works, so which is great. But they wanted to know, okay, well, if we look specifically at rectal cancer, how well will it work in this population? They expected that it would work. They just weren't quite expecting the results they saw, which is that it worked fantastically well across the board in every single one of those patients, and basically left us with, I think 100% of the patients had their tumors disappeared, and it's too early to say that there's cured, but that's certainly what they'll be following up with those patients about.
Yeah, just to point out that the time frame, the story that came out this past summer was reporting kind of a 2-year delay, right? They wanted to make sure that monitoring these patients, they had remained cancer-free for at least that amount of time before they published. And so it sounds like they published New England Journal of Medicine, and then New York Times picked up the story kind of right upon the publication. So obviously they were kind of monitoring this going on. So with that remarkable response, let's talk a little bit about who these patients are. Like you mentioned, the first they had kind of done colorectal, and then this was particularly for rectal cancer patients. And then could you talk a little bit about what else were the requirements for them to enter this study?
Yeah. So the most important one, and actually it's interesting because, it really does demonstrate the shift in scientific thinking and medical practice from one that was centered before on organs like rectal cancer, colon cancer, to genetics. And now we're talking about this MSI-High signature in the tumor itself. And again, it doesn't really matter where that MSI-High comes from, in terms of which organ the cancer started. Could be lung cancer, could be pancreatic cancer, could be ovarian cancer, could be colorectal cancer. right? And so all of those have some proportion of patients who represent this MSI-High. And so to me, what is really the most important part is actually not the rectal cancer, but the fact that it's MSI-High that they're studying. And that's where we're trying to figure out, sort of as doctors, as the FDA, how do these interact and intersect? Clearly, the traditional way of looking at drugs is in the cancer type by the organ, breast cancer, colon cancer. And now we have this very important asset, which is the genetics of the tumor, the MSI-High. And, clearly it can work, maybe a little better, a little worse in different, organs. But overall, we expect that it's going to work across the board. And that's really exciting. And I think something that the study didn't, or the New York Times didn't necessarily pick up on as robustly as we have internally.
So you mentioned this MSI-High. What percentage of cancer patients, have this, and what is it? Can you talk a little bit more about kind of what it is? And because you mentioned that it's kind of what's going on in the tumor, but how could a patient kind of better understand that?
Yeah. So we'll talk a little bit about what it is, but then the most important thing is how to find out about it, and how to find out if patient specific tumor has it or not. So again, what the cell, all of our cells have machinery that help the cell. They're like basically editors of a journal or a newspaper, right? They help the cell to make sure that no mistakes are being made in the texts that are being written. The text is the DNA. It's the code that tells the cell what to produce, the proteins, everything that the cell does is what the DNA tells it to do. As the DNA is replicated to make more cells, errors can occur. Those editors, the edit checkers, they make sure all the spelling mistakes are fixed and that sort of thing. Now, if they break, then we have a problem, because now mistakes will happen. And then those mistakes get propagated, get basically passed on to future generations of cells. And that's indeed how cancer begins. And so, but, cancer can begin, just out of, one of these errors getting passed on. But imagine if the spell checker is not there, there's going to be a lot more errors getting passed on. That's the condition that we're describing as this MSI-High, microsatellite instability. There's an instability in the cell. It's not stable, that those edit checkers. And so you could see how there'd be many, many more mistakes being made. And again, while that can lead to cancer, and we all know that, that's why the patient's coming to us, is that they have cancer. But now, knowing that, we can specifically attack or teach the body to learn and to see those cells that are basically without those editors, and then the immune system will attack them. And so that's the discovery. And so how do you find out if you have this condition called MSI-High? And the answer is through genetic analysis of the tumor. We recommend that all patients who have cancer and are high risk get an analysis of their tumor by genetic sequencing, something called nextgen sequencing. And we talked about that in our previous webinar. We'll be talking about that a lot more coming up. But this is a test offered by multiple companies. They're all pretty good. And so, but getting that analysis is really important. And what we know is that a very small fraction of patients get that analysis today, something in the 2 to 5% range. Now, every patient should have it. It will tell you more than just the MSI-High. It will tell us which areas we can look at in that tumor to attack specifically. But MSI-High is included in that. And you'll find, and the patients will find out if there are MSS, which is microsatellite stable, that's a negative finding, or if they're MSI-High, which is the same condition that's represented in this study, and that, of course, we interpret as a positive finding, that we now have an avenue to attack it. You asked what percentage of patients have this change.
Yeah.
It's about somewhere between the 5 and 10% range.
Wow.
Again, depending upon which cancer or organ you're looking at. That being said, again, if we could say, well, we can, cure, 10% of cancer today, that people don't know can be cured. That's a pretty amazing thing. And that's why this study is so good, is because they showed that if they do have this change, the chance of the drug working is extraordinarily high, and it works extraordinarily well. And so from my perspective, it really does emphasize that every patient needs to have this tested. Just before I stop, I wanted to mention that even though this change only represents somewhere in the 5 to 10% range, if you look at all of the changes that we can then attack scientifically and that we have medicines now to do, that goes up to about 80%. So if you get a test like this, it's not the 5 or 10%, it's the 80% chance that we look at, because there's an 80% chance it's going to tell us something that we can utilize to help the patient.
Yeah, that's actually what I was going to ask. I mean, that's what I was thinking is, so somehow these patients found this study, either through their oncologist, somehow they ended up at the door. And probably one of the first things they did for screening was say, well, if you don't have next-gen sequencing and these diagnostics, we're going to get them for you, because you're only going on this study if you have this MSI-High. And so I'm sure some people were tested and they didn't have it, and they said, sorry, this study is not for you. But and then for those who did, they say, okay, this study's for you. But I'm sure that it kind of unlocks a treasure trove of other options because they had that testing, right?
Yeah, certainly that's what we would think. We don't know. They
Right.
don't tell us what happens to the patients that they sent away. But this study was done at Memorial Sloan Kettering. And
Right.
again, being a tertiary care center, being one of the leaders in oncology, again, we'd imagine that they are being a bit more aggressive about getting those patients tested for tumor sequencing. However, we find that many patients fall through the gap. So again, we advise every patient to ask about getting their tumor tested with this genetic analysis next-gen sequencing, which includes the MSI-High. And so you could ask the doctor for any one of those things that will trigger this test.
So let's talk a little bit about how the test works. So it is a testing of your actual tumor material, correct?
That's right.
So is that usually, as I understand it, a biopsy is generally taken, hopefully minimally invasively, but they might have to actually do a surgery to get the biopsy material. That material is what's used by the pathologist to actually decide the diagnosis of the cancer. And it's that same material that can be used for this?
Absolutely. And again, there's a variety of sources, as you mentioned, right? This could be a needle biopsy where just a small piece of tumor was collected. That's suitable for this sort of testing. It could have been a surgical resection where the tumor, either some of it or the entire thing, was taken out, and that can be utilized for this sort of testing. Nowadays, there's a third part, which is that if there's not tumor available, and again, for various reasons, there may not be tumor available to be tested, we can look in the blood and see circulating tumor DNA called ctDNA in a test called the liquid tumor biopsy. So really, patients nowadays have multiple options in getting this testing done, and we're able to get this testing done for all of our patients.
Is this automatic for most cancer patients? Like, you end up in an oncologist's office and they say, absolutely, let's get this done.
One would hope so, and in some cases it's more automatic, but the fact is that cancer is complex, and there's a lot of things going on with patients when they have cancer. They could be having severe symptoms. They need to learn about other, even the standard of care, which is oftentimes routine chemotherapy, traditional chemotherapy. They need to learn about other aspects of, when they need to come back to visit. They might have financial concerns or other insurance concerns. There's a lot there to go through. Oftentimes, what we find is that still today, the next-gen sequencing, this genetic analysis, doesn't get spoken about initially. And then oftentimes, treatment will start with traditional chemotherapy, and it slips through the cracks. So we find it's a really helpful reminder to take one of our reports or our words and, say to the doctor, hey, I heard about this next gen sequencing, this MSI-High, is this something that could be analyzed in my situation to see if it would help me? And with that, really invites a discussion, and I think we'll have much less pushback than what might otherwise happen if they don't mention anything at all.
Excellent. I want to ask about two other things that came up when I was reading the article from the Times. One was about just staying on MSI. We talk about the tumor material, but as I understand it, it can happen in the tumor, but it can also happen in the person's overall genetics. And I think that some of these mutations and MSI-High can be passed down to children if it is kind of at the genetic DNA level of the person, right?
Yeah, so there are conditions, just like most of these genes, what we're looking for and what we've been talking about are genes that are just changed in the tumor, that are normal in the person. Those changes can happen in every cell of the person's body, either through inheritance or spontaneously when they were born or when they were conceived. But and that's it's a pretty rare situation. It does exist. And actually the model for that is what taught us that these things are present, right? That we can look at these genes. And so there's a condition called hereditary non-polyposis syndrome, HNPCC. And that is what we're talking about here is what we call a genomic sort of predisposition to cancer, where those edit checkers are not present in the patient's body at all. Those patients will have a course where they get cancer much earlier than the usual. So they are getting cancer at the age of about 16, I think, on average. And it starts with their colons really being filled up with polyps. And so again, families who have this, there's a support group for them, an advocacy group specifically for PCC, and they can and they are watched quite carefully by doctors and oncologists, basically right from childhood. Now, I think there was a situation where one of the patients in that study actually, I think, did have a genomic disposition to this and wasn't aware of it, and thus was made aware. And it certainly, these sorts of things are, we can detect them on the testing that's being done. And so, again, if that should come up, then certainly advising the family and having them tested is something that could additionally be done. But again, it's very rare. There's no reason to think just because you have cancer that it means that your kids are going to have cancer as well. But sometimes that does happen. And so in cases like BRCA or this HNPCC, it's important to find out in another reason to get the genetic analysis of the tumor done.
And I'd say to anyone listening or watching this recording, there are genetic counselors, so you can definitely talk to your oncologist about speaking to one to find out if there are any implications for your family or any heightened screenings that should be thought about. That is a resource that should be available to you. If you find that it isn't, contact us at Sage Health. We'll point you in the right direction.
And in a future webinar, I think we can discuss some of the indications, like when might you go think about this and when might you go to a genetic counselor to ask. Probably a little outside of the context of our discussion today.
Yeah, we can definitely do that. So the other aspect I want to ask about, which is the main patient featured in this New York Times article, I think her name was Sasha. She had been diagnosed. She had moved to New York. She was ready to face the standard treatment. She was going to have surgery, probably have a rectum removed, colostomy bag, kind of go through all this. And because she ended up on this study, none of that happened. And so it strikes me as interesting that the patients that went on this study, it was their first treatment. Could you talk a little bit about if there's a little bit of a change in thinking there, if that's kind of unusual?
Yeah, absolutely. And, the fact is that, the way drugs are developed today, and largely because we initially don't know the risk for safety for those drugs, they start with patients who have widely metastatic disease, or sort of, the highest risk in terms of survival. And so, and the FDA really does monitor that quite closely. And so oftentimes these drugs are started and tested in those individuals first with the hopes that they work. But when they work, they work with some moderate success. They're not always a cure at that point because the patient's disease just may be too far gone. As drugs get more and more developed over time, those drugs will be moved up earlier. And so the studies that had been done prior to this were looking at things like adjuvant, which is, I've had surgery now for colon cancer or rectal cancer, and now I'm giving this drug as a way of preventing the tumor from coming back. One step earlier from that is where we find this study, which is, well, let's see how well the drug works in newly diagnosed patients with rectal cancer who have this MSI. And let's see if we still need to do the surgery. We still need to do all these things with the expectation that we would. But the surprising finding is that some of those patients don't have a cancer now to operate on. And they're watching closely to make sure, but they've been, a few of them have been able to avoid surgery completely. And again, this is the sort of thing that we hope becomes the standard one day, and one day soon. I think patients can really be advocates for themselves by opening up that gate, by asking the question, can I have that tumor sequencing now, right at the very beginning, so that we could utilize those results and figure things out? The doctor may be willing to give the medicine before the surgery. They may not. We may need to be on a trial for that or find another doctor. But that's where we can help patients to find the best possible scenario for their situation and have the best chance of coming out with that without a tumor, just like these patients in the study. And so it's enormously exciting.
It certainly is. So let's talk a little bit about the drug. I mean, they were, all the patients on this study were given one particular drug. They all responded to it. What kind of drug was this? What was special about? I mean, you've mentioned that it was immunotherapy, but can you give us a little bit more information on what you understand about this drug?
Yeah, absolutely. So yeah, so this drug comes from a class of drugs where these are going being designed to help the immune system to see that tumor. We mentioned that that there's this MSI-High situation, and there's a lot of mutations. The tumors, though, are able to basically deflect and hide from the immune system. And the way that they're able to do this is by producing a protein called PD-L1. This drug, which is an antibody, a protein that goes and blocks another protein. This is a PD-1 antibody. And so when it goes in, it basically sits on the PD-L1 and blocks it. That tumor now can be visible to the immune system. The immune system starts seeing all those mutations and saying, whoa, that's not supposed to be here. Let me go and, tell those cells to die, wipe out those cells. And thus the immune system is responding to the tumor. As I mentioned, there are a number of drugs that do this. This one was durvalumab. Actually, it was Dostarlimab. And again, durvalumab is another one. There's actually like I think about 8 or 10 of these at this point. I think the most famous ones are ones that are pembrolizumab, or Keytruda is the commercial name for it. Nivolumab, Opdivo is the commercial name for that one. I know that the tendency for cancer patients is to fixate on the drug and say, hey, doc, like, I saw this study about Dostarlimab curing all rectal cancer. Can I have some of that? We find that that's probably not the best question to ask. One, because there's multiple drugs that all would have the same effect. Two is because it's easy for the doctor to say, no, only 5 to 10% of patients really, would benefit from that. And we don't, we don't know that you're in that bucket. So no, you can't have it. What we find it's better to ask is that question that we talked about before.
Mhm.
Hey, doc, I saw this exciting study in the New York Times about rectal cancer and MSI-High. I'd like to know if I could have the test that would show me whether I have that or not. From that point, it would be obvious that if you have it, that you would deserve that medicine or any of those in that class, and thus improve, and have the same sort of exciting outcomes that those patients experienced. And again, just to mention, could be rectal cancer, could be any other sort of cancer. Again, that's at high risk. And thus, again, the advice, the guidance that all patients get this kind of genetic testing if they're at high risk.
Yeah, I mean, and I would also say, I mean, the genetic testing often will kind of qualify you for clinical trials. I mean, that's where the 80% that you mentioned of kind of like, what can we do based on what we learned from that is going to be in trials, and just kind of put some numbers around. I mean, there are 13,000 trials for cancer that are kind of going on at any given moment. So the idea, and each of those kind of represents a different drug or a different combination of drugs or a different sequencing of drugs. Like there's so many things that are going on there that, that idea that, you read this study in the New York Times, I think I just want to underline what you're saying, which is that, like, yes, this is remarkable for a small percentage of cancer patients that qualify, but it's really this testing that almost 100% should get, because you know where you fall, what your options really are. And that could be true. I just want to underline for anyone listening, like we're talking about this as like their first line of treatment. It doesn't have to be your first line of treatment in that case. It's very much that wherever you are kind of in your rounds of treatment over time, this can always be a factor. And a lot of times clinical trials have traditionally been left as kind of the last resort. And now it's kind of like they can be considered all the way along. So along those lines, I'd love to kind of close with you just telling a little bit about what Sagely Health does. I mean, when we meet a patient with cancer, regardless of where they are in their treatment, I'll call it a journey, use whatever metaphor they want, what can they expect to kind of have happen when they go to Sagely Health, and why do we do that?
Yeah, absolutely. And again, we're here to advocate to help patients get their best possible outcome. And so we do that through listening to the patients and finding, hearing about what is their story, what kind of cancer do they have, what sort of treatments have they had already or not, and who are they being seen by? What are they looking at in terms of treatment options? Many patients don't have many treatment options or don't know. And so what we do is we go through a very deep-based search for them, looking across all of the clinical trials that are out there in the world, and as well as a lot of the the questions about these diagnostic tests, this tumor sequencing genetic analysis. Did they have it or not? MSI, do they have it or not? Other things. And then we can go back and tell them specifically, what options we think they should work on right now, who they should ask for those options, whether that be a clinical trial or a diagnostic test. Maybe it's their doctor, maybe it's a different doctor. And what questions they should ask to make sure that they are able to get that testing done and find the drugs, get access to the innovative therapies that we identify. Because to us, that's how we ensure that our patients get the best possible outcome. And over the years, we've been also enjoying success along that route of doing that in that way.
Excellent. Well, yeah, I mean, just to put a couple more numbers on it, I mean, we found that our patients are 10 times more than the national average likely to enroll in a clinical trial. We don't recommend clinical trials for every patient, but, it's definitely in the conversation. Our study of we're kind of randomized study of our patients, we've extended lives, and we've pretty much in about 90% of cases, we have changed the course of their treatment in some way. We've had some insight that said you could be having a different standard therapy, you should be having a different diagnostic, you should be trying to enroll on this trial. The kind of real changes have happened. So, Jason, anything else you want to add before we close here?
Yeah, no, I mean, it's enormously rewarding, and this is why we do it every day. And I'm looking forward to helping many, many people in the future. So, and as well as having more of these webinars. So thank you for everyone for joining.